So we have about 30 minutes, and we're going to enter a little segment called Ask the Midwife.
Ask the Midwife.
So I asked my friend Dana to come join me. You want to introduce yourself, Dana?
Hi.
Everybody did introductions earlier.
Okay.
Name, pronouns, identity, and anything you want to share about your work.
Okay. So my name is Dana Gordon. My pronouns are she and her. I am a community midwife. I've been in private practice for about 17 years now. I'm here. I'm happy to be here. So I have 4 children of my own that I've all delivered out of hospital, and between 20 and 8. So every developmental age crisis you can imagine right now between that whole range. But yeah, so thank you for having me.
And Dana and I have worked together to do birth assistant training in the past, and we are working on establishing a midwifery program, a 3-year midwifery program to train midwives from marginalized communities. That is a program based in social justice. So stay tuned for that.
Yes.
So I think we just wanted to share a couple of tools with you that we use. And so we practice out-of-hospital birth. We deliver babies in home and birth center settings. So it's an alternative to hospitals that is becoming more people are using because of the high C-section rates, because of concerns of substandard care or poor quality of patient interaction with doctors and nurses. Sometimes people choose it just because they want to be comfortable in their own home. I know for me, wearing my own clothes and eating my own food and being in my own bed after I gave birth was really important. Being able to move around and not being, having to stay in a bed. With my second baby, I delivered in a hospital in Georgia, and I got into a fight with a nurse during the birth because she told me that if you get out of the bed, you're going to kill your baby. And I had a doula, and my doula literally stood guard at the door while I hid in the bathroom and managed my own labor. And I said, never again. Never again. I'm going to have my babies at home. So I moved to Florida to study midwifery, and I had 2 babies since I've been here. And I had 2 beautiful home births that were attended by midwives. I was able to move around and birth on my own terms. I birthed in the water. And I had a lot of postpartum support, which was also something that was lacking from my previous births. My midwives came to see me the day after I gave birth, and a few days after that, and a couple weeks after that. So I had a lot of postpartum support as well, which was really, it kind of completed the circle for me. It made it, a whole process. So yeah, do you want to say anything about midwifery care, about birth assisting?
So typically in midwifery care, we see the client through their entire prenatal period while they're pregnant. Sometimes we do like preconception counseling as well and support in that process. We are there through the labor and delivery. Typically, if the baby has transitioned well, the client has transitioned well, we stay about 4 hours postpartum. By about that time, the client's ready to just cuddle up in bed with this new baby and have their space. We then return 24 hours after the birth. We check the baby, we check the client, we make sure that everything is normal, that they're receiving services that they may need. Possibly we may assist in food support in their community, with their friends, with their people to orchestrate this type of support. Encourage support for maybe childcare with older children. We see a sink of dirty dishes. We'll quickly wash up those dishes.
I don't know about that, Dana.
Oh, I've been getting this wrong
somewhere.
this whole time. Listen, if it's to avoid
I'll do a load of laundry, but dishes,
okay.
I drop them.
I don't prefer the laundry. I'd rather just wash up those dishes.
Anyway, we do help around the house too.
And then we're following that client and the baby for 6 weeks postpartum. And some clients choose to engage with their pediatrician during that time. There's other clients that either transportation's challenging, maybe they don't have insurance, so we kind of hold space for them for that 6-week postpartum, and then oftentimes we're connected to our clients
Forever.
indefinitely. Teething, trying to find the right daycare situation, so it's a very intimate relationship. And typically that's why we don't overwhelm ourselves with births through the month, so that we have the availability to really meet the needs of those clients that, fully, without sacrificing our own well-being as well.
Yeah, I think the average midwife takes on about 4 to 6 a month. That would be the max, so that we can give that really close attention to each individual family. Because it's not just the birthing person that we're taking care of, the whole family, really. So just a couple of things about midwifery. Direct entry midwifery, which is different than nurse midwives. Nurse midwives primarily practice in hospitals. Direct entry midwives, which in Florida are called licensed midwives, primarily practice in birth centers and homes. And usually we don't have hospital privileges. So if we have to transport, we're handing that care off to either a hospital-based midwife or a doctor.
To really midwifery-friendly OBs that want to receive us.
And we're always looking for friendly,
relationships.
It's hard to find friendly OBs that support midwifery care, so we're always looking for those relationships. But midwifery is legal in 32 states and unregulated in 11 states and illegal in 9, I think 8 states now.
They will prosecute.
Yeah.
In those states.
So we're really blessed in Florida that we have direct entry midwifery, that there's formal training programs, and that it's licensed by the state, and that all insurances have to accept midwifery midwives on there, to bill, including Medicaid. So anyone, and I get this question frequently, anyone can have a home birth. And there are even programs like Southern Birth Justice Network. We have a birth grant to help folks that are uninsured and would like to have a home birth. We take care of low risk and normal pregnant folks. So that means that there's no high risk complications. We go through a detailed checklist with each of our clients to find out their health history, if they have any high risk issues or anything that's a potential flag. For example, if they've had a previous C-section, then they have to meet with our backup doctor and get a sign-off that says, yes, it's okay for you to have a home birth. And there are certain things about the C-section that we would want to know. Like, was it a transverse incision going across and not classical or vertical? How long has it been since the C-section? Was there any infection or, complications with it? What was the reason for it? Those are things that would be asked so that we could determine if this person can safely have a trial of labor at home. But the success rate with VBACs at home is very high because of the lack of intervention and the level of preparation I think that midwives do, and that trust factor that's built between a midwife and the client. It definitely increases the outcomes. I think the last study that came out, home birth, out of hospital midwives have a 95% vaginal delivery rate. And for C-sections, I think it was at like 75-80%. So pretty high, and success rates. And something like 98% of our home birth clients breastfeed. And tend to breastfeed for longer periods of time too. So there's a lot of support given around that. Want to talk about the golden hour?
So the golden hour is that first hour after that baby's been delivered. And so that is an hour that we really hold sacred. It's an hour that the baby gets affirmation that they have done their job well, they've done their job right, that they made it through that process. It is that client's chest is home base, and so it's that keeping that entire unit, which is still one unit, just really encapsulated in allowing the process to take place. So there's a hormonal exchange that takes place. The baby's releasing oxytocin from the top of the head. That's typically why we don't cover a head with a hat unless the baby, truly needs that warmth support. The mother is smelling in that oxytocin. It is like the greatest love affair that takes place when that's uninterrupted. And that allows that client to throw themselves in front of a train for this child. Like, it is such an intimate time. It's also they're regulating each other, and that the baby is seeding its immune system by the hormones that are being released from that birthing person. The baby's licking its hands, licking the breasts, licking the chest, and it's seeding that immune system. It is, it's a very primal, time, and we do our best. I guard that very, very much like a warrior, that baby is not being passed around to the auntie, to the mother-in-law, that is such an intimate relationship, even the partner. Like that, let's first establish home base. And there's milk regulation that's taking place. If the baby is lying on one breast and the baby is cold, that one specific breast will warm up to create warmth for that baby. Some babies need a little more support transitioning. Maybe they've had a challenging birth, maybe it's been long, maybe there's been some intervention that's been necessary, some of the shoulder dystocia, things like that, and that baby really needs some support. We do whatever we can to bring that support straight on the chest of that client. And so we will turn that baby over and rub that baby up, but we want that physical contact. And if we have to move the baby over to, we carry cutting boards to use as like support. So if we have to do, we have to resuscitate, we have to do anything. If we can, bamboo bag. If we cannot support that baby directly on the chest of that birthing person, then we do it right next to it, and we encourage that client, talk to your baby, tell your baby to come into its body, rub that baby, make that physical contact. We, everything that we have, we keep the placenta intact at that time. We don't cut the cord. We want the baby to utilize all that support, which is great because it also nobody can take that baby away. Also, like, we're tied together.
So if the baby
that's the
is
golden
struggling with breathing, then this is how we resuscitate them at home. There's this mask called the Ambu mask, and we're all trained in neonatal.
Yeah, right on the chest.
We're all trained in neonatal resuscitation. It's required for us to have this training every couple of years, and we put the baby either on the bed or on the chest of the mom, or on a flat surface, and open the airway, place the bag over the face, and then we give breaths. And of course, I can't get a seal on a plastic baby, but that's how we, help the babies breathe. About 10% of babies will need a little help breathing at birth. That's the statistic. Most babies do fine. You just, like Dana said, give them a good rub and they let out. But some babies need a little extra support. But the point is that we try to do it right there and not remove the baby. And most of the time, even if the midwife isn't present and babies sometimes just come, at home, most of them will do great because birth is a natural process. And a lot of people do birth unassisted. It's not, necessarily something I'm encouraging, although I will defend someone's right to do that. Just like I'll defend their right to make any reproductive choice that they want to make. But, most of the time, even if a baby's coming fast, as long as it's full term and the pregnancy's been relatively healthy, you hear those stories all the time. Like, my baby just came fast, I didn't make it to the hospital, right? And usually if the baby's coming fast, then that means nothing's in the way and baby just slides right out. And then, it's just a matter of like rubbing the baby up and making sure that they let out a good cry, getting them warm, and keeping them close to the person that gave birth to them, to the mom, and watching for blood loss. So if you find yourself in that situation, you really just want to get that baby skin to skin as as quickly as possible, and put a blanket over the mom and baby, and just watch for bleeding. Yeah. Do you want me to pull up the warning signs?
Sure.
Maybe you want to show some of the other stuff already, because this thing has been slow today.
So we also, every prenatal that the client is in our office, it's a reassessment of is this client still healthy and low risk to be able to deliver out of hospital? If in the event that a client comes in with a really elevated blood pressure or something like that, most of us have relationships with a backup obstetrician who that we call and consult with. We may refer that client to their office, and sometimes the OB will say, this was an isolated incident, I feel comfortable with this, you're welcome to have this client back, or we'll do collaborative care. Or the client may transition into the OB's care if that's the appropriate setting. So, we do what's normal and what's low risk and utilize around us when it steps outside of that boundary. So we do part of those vital signs. We check the blood pressure.
Anybody want to be a blood pressure volunteer?
Does anybody take blood pressures in here? You all? Yeah? You want to take? Oh. So we take the blood pressure, we check the temperature, we check the pulse. We are measuring the fundus of the uterus, so that's the top of the uterus from the pubic bone to the top of the uterus, and that should correspond with the weeks pregnant that the client is in centimeters, and so that gives us an indication of, is this baby growing within normal limits? If not, we might refer this client to for an ultrasound to ensure that the baby is growing well. We do lots of questions. How are you feeling? What's going on in your home? What's going on in your family? What's your stress level like? Do you feel prepared, for this birth? Are you seeking childbirth classes? What is your postpartum plan? So we do a lot of this support. I would say our medical aspect of our prenatal is maybe 15 minutes. 20 minutes. The rest is, okay, where do we need support to have an intact birth, to have an intact relationship with your baby, with your partner, with your other children? What's going to happen when your mother-in-law is insistent on being at the birth? How do we do that? So it's this type of thing. We also listen to the baby's heart tones at every visit, and we make sure that the baby sounds well. We instruct the client to do like kick counts at home to ensure well-being in between prenatal visits. Take somebody's blood pressure. Somebody want to go for a blood pressure? Look at what else we have here. We also have a scale that we weigh the baby with.
That's what we use to weigh the baby after the birth. So, baby is in here. This baby doesn't weigh very much. That's how this. Oh, we had a less than 1 pounder. But usually they're between 7 and 9 pounds. Yeah. And we do a home visit at 36 weeks to check out the home, make sure they have everything they need, discuss who's going to be present at the birth and what the roles of every person is. And at that time, we definitely go over what to do if the baby arrives before the midwife. And that's usually the partner, but sometimes another family member or the doula that is in that role of helping to deliver that baby should the midwife not be there yet. And then for my clients, if they call me and say I feel like pushing, I'm on the phone with them the whole time while I'm doing 90 miles an hour to get to them. So it has happened, but yeah, I'm coaching them through the whole process. You can take another blood pressure volunteer because we have these wrist cuffs too.
And typically that scenario looks like us driving like a bat out of hell on speakerphone, like praying that all our guides are guiding this car because we are like hydroplaning all the way through, trying to get there. And EMS is also an option. Like if the family is not comfortable with this process and we're 20 minutes out, absolutely call EMS. You could refuse transport, but you could just have them there on standby in the event that there's an emergency.
This is, I don't know, this is kind of a weird question, but like, you know, in pop culture, it's been kind of trendy lately with the whole like saving your placenta and stuff like that. What if a mom delivers unassisted and she wants to preserve it? Do you guys cope with that, or is that like a whole separate industry of birthing professionals that do the like placental preservation and all that?
So I do placenta encapsulation. That's one of the services I and yes, so after the baby is born, then usually anywhere from 15 minutes to an hour later, the placenta comes out. We don't overmanage delivery of the placenta. As long as there is no concern for bleeding, then we just allow the placenta to come when it comes. You know, if the placenta's inside and the baby's on the birthing person's chest, the cord is exactly the right length to go from here to here. Or it's nature's design that way. Again, you know, that golden hour to just protect that time. So then when the placenta comes, we usually wrap it in a Chuck's pad or put it in a Ziploc bag. And we don't necessarily cut it right away because the baby is getting the benefits of, you know, the oxygen and nutrients from that cord. So we do delayed cord clamping. And then once it's cut, although some people actually don't want to cut, every now and then I have a client that wants a lotus birth, which means that you don't separate it at all. You just let the cord fall off whenever it's ready, still attached to the placenta. And that usually takes a couple days. And people will pack it and put herbs on it and good smelling stuff so it doesn't deteriorate. And then those placentas cannot be encapsulated. But if they want to do encapsulation, then we separate usually after about an hour when we get ready to weigh the baby. And then I will take that placenta and cut off pieces of it, put it in a food dehydrator, dehydrate that for 12 to 24 hours, grind it into a powder, a very loose powder, and then put it into capsules. And then the person can consume the capsules, and it gives them back some of the hormones because you get a big hormone drop after pregnancy. You know, you get all these high hormones to give birth, and then 3 or 4 days later it drops, and people get baby blues, which can turn into postpartum depression. So the pills help to rebalance that, gives you back some of the nutrients that that you lost in the process, and that hormone boost also can help with the breast milk supply. So there's some benefits there.
I encapsulated my placenta when I delivered it, and I had a tincture, and I swear by it. I swear by it, and I would love to learn how to do it. So if you're going to do a training on that,
People have been asking, so
Yeah.
I feel it coming on.
Feel it coming.
it's a lifesaver.
There's also a companies that come around and actually, at my wife's birth, there was a company that came around and said, hey, you want to give us your placenta? We didn't do it, but they use it for like research purposes. That's what they say. I don't know what they use it for, honestly. So we just opted not to do it.
Yeah.
But just know that
Don't they make
there
facial
are people
cream?
at Jackson, for instance, who will come and they just collect it.
Wow.
They won't pay you for it. Just know that those exist too.
Interesting. Placenta encapsulation usually costs around $150 to $300, depending on what you get. Like some people do tinctures, some people just do the pills, some people do like placenta art, like prints, and all kinds of cool stuff. But yeah, that's usually how much it costs. So it's not accessible for everyone. And I do sliding scale, so I discount my rates for people who can't afford it.
But in Cuba, for example, it's not out of need because of not having access to a lot of medications and to the blood. They cure vitiligo. They cure a lot of conditions with the placenta.
Yeah, placenta has stem cells in it. It has so much
There's
healing
conditions
stuff.
that don't have a cure here, eye conditions, and you go over there, and then all the medications is done with the placenta.
And it's been used in ancient Chinese medicine forever.
And Jackson is making a buck off of that.
Have you ever run into an incident with a hospital that won't allow you to take the placenta? I haven't experienced it, but I've heard of it.
Yeah, definitely. If someone wants to take their placenta, they should have it in a written birth plan, and they should communicate that to the hospital staff. As soon as they get there. Sometimes it's a bit of a negotiation, and sometimes they'll come up with reasons why you can't take your placenta. Yeah, it's your organ that came out of your body. You should be able to take it, absolutely.
But they'll say it needs to be run through pathology. They'll drag out this process.
And then sometimes they'll throw
They won't
chemicals on
locate it. They
And then they'll be like, oh, we put chemicals on it, so sorry, you can't take it. So communicating that early and often at a hospital is really important. Usually you have to have a designated person that's picking up the placenta. Sometimes you have to supply your own cooler with a biohazard bag. So knowing all that stuff ahead of time is important. But yeah, sometimes hospitals give issues with keeping the placenta.
My placenta was put in formaldehyde. I was trying to keep mine too. And they came to me at like 3 in the morning. The people who were working in the lab, it was an accident, So, and they apologized though. They were like, "Are you gonna eat your placenta?" And I'm like, I didn't know what to say. I was like, I was gonna bury it with plant a tree or whatever. And they're like, well, if you're gonna eat it, I can't give it to you because it has, it's in formaldehyde.
Do you believe them, or do you think they sold?
No, I believe them because they actually confided in the 2 people who were working in the lab.
Oh wow!
Yeah, they lost their jobs. I was like, I don't want someone to lose their job, but I was glad that they were taking it seriously.
Right.
Because what if they didn't say that and I took it home and ate it?
Right.
Yeah.
That's crazy.
Does medical intervention change the quality of the placenta? So, like, if you have epidural or oxytocin, like, do those chemical injections, like, change how you use the placenta thereafter?
Well, they do cross the placenta.
Right.
And what I know about Pitocin that's been shown in studies is that it blocks the release of oxytocin, which is the body's natural hormone.
Right.
So that placenta would probably have less oxytocin. But I don't know if there's been a study done specifically on that question.
The one thing though is that the oxytocin is more for the uterus. The actual placental structure doesn't. What the medications can do is just affect the flow through it, but not the actual composition or the structure of the placenta. That makes sense? Right. So you can still use the capsules
Yes.
in the same capacity.
Yes, we can. Good questions. Those who are interested in continuing learning more about pregnancy and how to assist midwives, be helpful to pregnant people, and possibly even think about becoming a midwife, we are going to be offering a birth assistant training soon. And birth assisting is a career. People make a career out of birth assisting. Attending.
They make more money than we do.
Sometimes, yeah. Attending births with midwives, because midwives always take an assistant with us because we have a mom and we have a baby, and we have to sometimes provide care for both of them at the same time. So we always have trained assistants with us. And the birth assistant training is a 40-hour training. It's very comprehensive, and we spend lots of time on these skills. Like, you get checked off mastering it. So today was a quick overview, but if you're interested in really going deeper with that, that is something that we're going to be offering soon.
What is the minimum age to start?
Birth assisting?
Yeah.
There isn't one because it's not a certified or licensed field. For midwives, you have to be 21. But for birth assistants, there's no minimum.
And there's no certification. She's 16. Like that.
Absolutely.
And there's no certification or license.
We provide a certification, but there isn't one that's required by the state or anything like that. You're welcome.